Okay, this lecture covers Chapter 3, which is the Introduction to Uniform Hospital Discharge Dataset and Official ICD-10-CM Coding Guidelines. UHDDS stands for Uniform Hospital Discharge Dataset. It's a basic common core of data elements that's captured on every hospital admission. It was originally intended for acute care and short-term hospitals, but now includes non-outpatient settings. This, in addition to acute care, is short-term, long-term care, psychiatric hospitals, home health, rehab, nursing homes, and others. Some of the data elements include the personal identification number, such as a health record number, medical record number, date of birth, sex, race, ethnicity, residence zip code, or a country code for foreign residents. Each hospital has a unique provider number, along with physicians having a UPIN number. That's a unique identifier for that particular physician. We also cover admission and discharge dates, where the patient is discharged to, or as it's referred to as the disposition of the patient, and the expected payer for the bill. Clinical information is also part of UHDDS. All diagnoses reflecting the current hospital stay must be reported and coded. This includes significant procedures, dates, and who performed the procedure. We also have the principal and secondary diagnoses and procedures. We'll talk about those in just a little bit. The principal diagnosis is the condition established after study to be chiefly responsible for the reason the patient was admitted. Any other diagnosis that coexists at that time is also coded. So something you really need to know for the quiz and beyond is, what is the principal diagnosis? A complication and a comorbidity are also important to capture. It's an additional diagnosis that has an impact on the payment received through the MSDRG, or Medicare Severity Diagnosis Related Group. This is a prospective payment system that we'll talk more about in the course. A complication is an additional diagnosis that describes a condition that arose after the patient was admitted and modifies the course of the treatment. A comorbidity is something that already existed, but because of its presence with the specific principal diagnosis, causes an increase in the patient's length of stay. All significant procedures are to be reported. This includes, when you say reporting, who did the procedure and the date. A significant procedure is one that is anything that is surgical in nature, carries a procedural risk, carries an aesthetic risk, or requires specialized training. A principal procedure is performed for definitive treatment rather than diagnostic or exploratory purposes. If two procedures could be principal, the one that's most closely related to the principal diagnosis, in other words, the reason for the patient's admission, is to be selected. And again, a definition we'll see again and again. What is a principal diagnosis? It's the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. In other words, it's a diagnosis that resulted in the patient being admitted. So an example of this is if we have chest pain, they do a cardiac workup and they have an acute MI or heart attack. The heart attack is the principal diagnosis, not the chest pain, because there was no after study. The chest pain is what they came in, right? That's a provisional problem. And then they're worked up and they come up with a principal diagnosis. The term principal diagnosis only applies to inpatient care. We don't have a principal diagnosis in the outpatient setting. All inpatient settings have to have a principal diagnosis. And it's similar but not the same as an admitting diagnosis. Going back to our heart attack example, the heart attack is the principal diagnosis. The chest pain is the admitting diagnosis. The key word here is after study. The coding guidelines were developed by three parties: the American Hospital Association, AHIMA, and CMS, Centers for Medicare and Medicaid Services, and the National Center for Health Statistics. These are updated every year. One thing that doesn't get updated is the principal diagnosis. The rules have remained the same. So we want to have a consistent, complete documentation of a principal diagnosis. There are guidelines that cover signs, symptoms, ill-defined conditions. Very important to understand this guideline 2A, because that determines what we code and don't code. 2B deals with two or more interrelated conditions, each that potentially meet the definition of a principal diagnosis. 2C along the same lines, and 2D, two or more comparative or contrasting conditions. 2E is no longer there, so we're not going to worry about it. 2F, guideline that specifically mentions what happens if an original treatment plan is carried out. And 2G covers complications of surgery. That's all I have for you. We'll continue on with this and talk more about principal diagnosis and talk about some outpatient guidelines. We'll see you then.